My name is Jonathan Newsome. I'm a student at the College of Nursing at St. Petersburg College. This research presentation is based on prevention of venous thromboembolism in hospitalized patients. The objective of this presentation is the synthesis of scientific research on the prevention of venous thromboembolism in hospitalized patients. The synthesis will consist of the selection of 3 peer-reviewed primary quantitative research articles published within the last 5 years. Scholarly sources will be identified and used to support the literature review, along with the critical appraisal of each article. VTE, consisting of deep vein thrombosis and pulmonary embolisms, is a major preventable complication in hospitalized patients that is triggered by immobility, surgeries, and multiple comorbidities. This complication in hospitalized patients contributes up to 100,000 deaths annually in the United States, with only 50 to 60% of high-risk patients receiving proper prophylaxis throughout this setting. Inconsistent use of prevention strategy is a major reason that cause reductions in use and ultimately contributes to adverse outcomes. This outcome makes it very significant for practicing nurses, as they are the frontline workers assessing risk, managing protocols, education, and monitoring outcomes in real time. Nurses use and develop interventions that align with quality metrics that apply safer care and provide better outcomes. The methods used for literature search began with a focused research question, which focused on interventions highlighting evidence-based guidelines in clinical practices. The use of proper databases such as PubMed, CINAHL, and Google Scholar was used to find relevant studies on VTE prevention. Search terms included combinations of venous thromboembolism prevention, mechanical prophylaxis, and risk assessment, as well as other based on findings. Inclusion criteria consisted of peer-reviewed articles published in English between 2020 and 2025. This criteria also focused on VTE prevention strategies in hospitalized patients, particularly surgical patients, and exclusion strategies immediately dismiss non-hospitalized patients in studies lacking empirical data. Articles also not available in full text or consisting of secondary analysis and non-peer-reviewed sources were also excluded from searches. Narrowing the search was made easier by using limiters such as study design type, focusing on randomized control trials, quasi-experimental, and experimental studies. Source selections were based on recent high-impact journals. Sample size was carefully thought about, as well as risk assessment practices. Subject headings include thromboembolism prevention and control, risk assessment, point-of-care systems, evidence-based practices, and clinical protocols and quality improvement. Article 1 is titled Effects of Computerized Clinical Decision Support on Adherence to VTE Prophylaxis Clinical Practice Guidelines Among Hospitalized Patients. This article employs a quasi-experimental design as the study utilizes a pre- and post-intervention design. 878 patients were enrolled pre-intervention and 938 were enrolled post-intervention. It is considered a Level 3 study. The clinical decision support system significantly improved adherence to VTE prophylaxis guidelines, showing pre-intervention rates at 45% and post-intervention rates rising to 72%, bridging patient gaps. The literature has shown a clear and consistent trend toward using digital tools like CDS, which has been proven to enhance guideline adherence. A major theme includes the involvement of the multidisciplinary healthcare team and the need for tailored interventions based on specific hospital areas for the prevention of VTE. Debates would focus on the reliance on manual versus automated risk assessment, highlighting the over-reliance on technology. As the CDS design was limited to hospital areas in a single hospital environment, the efficacy of CDS for universal application could be questioned. This leads to knowledge gaps due to the single-site implementation and the need for multi-center randomized control trials. As shown by the table for pre- and post-intervention rates, there was statistically significant improvement in VTE prophylaxis adherence from 45% to 72%. Risk assessment completion increased from 52% to 85%, and the proportion of appropriate prophylaxis for high-grade groups rose from 38% to 68%. It is important to note that increased negative bleeding events were not observed throughout the study, indicating that the practical guidelines were enhanced without an increase in harm. This demonstrates improved patient safety and nursing practice guidelines, while also highlighting the need for customized implementation to prevent knowledge and safety gaps. A systematic review and meta-analysis by Karajizadeh and others concluded implementation of CDSs showed similar outcomes for improved prophylaxis adherence. The review also highlighted CDS's roles for high-risk populations, confirming increased safety measures and decreasing harm. Article 2, titled Alert-Triggered Patient Education versus Nurse Feedback for Non-Administered Venous Thromboembolism Prophylaxis Dose, a clustered randomized controlled trial, is an experimental cluster randomized controlled trial randomizing 16 hospital units to either a patient-centered education bundle or nurse feedback intervention. It is considered a Level 2 study based on the hierarchy of research evidence, providing high-quality evidence for the efficacy of the intervention. Main findings show that both interventions significantly reduced the non-administered VTE prophylaxis dose. Themes included emphasis on behavioral and communication barriers in VTE prophylaxis adherence, real-time electronic alerts, and a nursing-led multidisciplinary approach. Literature highlights gaps in prophylaxis due to delivery, with trends toward technology-based interventions through alerts and education. Debates have arisen regarding whether education or feedback is the optimal strategy for addressing patient refusal, with the study favoring patient involvement. The study is limited to a single tertiary care center that could benefit from a multi-center approach. Implementation barriers in the study throughout diverse settings, patient demographics, low income levels for patients, and length of stay may have influenced finding. The survey done by Han et al. Is a mixed method systematic review that examines the barriers impacting the adoption of these practices and supports the approaches used to decrease biases and increase fair distribution. The review examines 25 studies and highlights the importance of the analytical models in a randomized approach. Further gaps consisted of nurses switching between hospital areas. Across 11,098 visits, non-administered doses fell 31% overall. Results consisted of real-time patient education being more effective in reducing all non-administration and refused doses compared with nursing feedback. Both alert-triggered patient education and nurse feedback enhanced prophylaxis guidelines and closed adherence gaps, minimizing VTE prophylaxis non-administration. Nursing practices are then improved through patient engagement in hospital settings and increased quality metrics when using feedback tools. Article 3 is considered a quantitative descriptive retrospective cohort study design with two non-matched cohorts, SED versus non-SED, comparing VTE outcomes in patients under identical ARAS protocols. It involves intervention exposure through the use of intraoperative interventions and is considered Level 4 research. Key findings include minimal VTE events with only 2 PEs throughout the SED cohort and none reported in the non-SED cohort. Literature trends favored ARAS elements such as early ambulation and minimal invasiveness over mechanical tools such as SEDs. Emphasis on pharmacological agents for cost effectiveness and sufficient prophylaxis was also used as a theme throughout the study, as SEDs could be seen as having incremental value for moderate risk patients. Gaps in knowledge would include the focus on symptomatic VTE events only, rather than the addition of asymptomatic events. Results determined that routine intraoperative SEDs provide no clinical significant VTE prevention in ARAS thoracic surgery patients. Risks can largely be mitigated through protocols that include pharmacological prophylaxis and multimodal care that reduce costs and burdens without harm. Nursing practices should focus on including ARAS protocol elements such as monitoring and education over mechanical devices. Future studies would be worth addressing, as larger randomized controlled trials would be needed to assess the need for higher risk patients. The 3 studies demonstrated the potential to optimize VTE prophylaxis through technology, behavioral intentions, and protocol reevaluation. Demonstration of CDS boosted VTE adherence by over 30%. Patient education bundles and nurse feedback overcame patient refusals, and interpretation of the ARAS protocol as sufficient challenge the norms of typical SED use. Through these protocols, the 3 studies found nurses can lead these practices through direct application to address persistent gaps in VTE prevention. Workload and resource management can be better optimized throughout inpatient hospital areas, and the integration of technology can also be better managed through tailored practices. Similarities include highlighting real-world interventions and adaptations throughout all the same environments. All studies target prophylaxis gaps in hospitalized surgical patients while also demonstrating improvement practices that do not cause further harm. Differences include study designs, including 3 different methods: quasi-experimental, retrospective cohort, and randomized controlled trials. Sample sizes and the use of various interventions, such as tech-driven versus behavioral, and outcomes, all varied. Limitations for all studies included the scope of the study with a focus on inpatient short-term outcomes, which had an impact on results. Diversity and cost-effective strategies were also an issue, as access to resources can be limited. Methodologies were all limited by each study, as all have single location designs. Key takeaways, including highlighting each of these evidence-based strategies for optimization, VTE, prevention in hospital settings. The emphasis on technology integration into healthcare practices by prompting risk assessment and providing recommendations based on feedback is growing more powerful every day. Adding more patient engagement exposure would be highly beneficial as it outperforms provider feedback. Mechanical prophylaxis can also be de-emphasized in specific areas and is essential to recognize how these strategies could save money and impact long-term outcomes. Further recommendations include addressing gaps, such as a single location design, as this could cause biases or change in short-term outcomes. Equity and cultural factors could be explored throughout the study designs for optimization of patient education and overall outcomes. Evaluation of the de-implementation of SED omission across multiple metrics, such as non-thoracic surgeries, could impact outcomes of the study.